Hi everyone, peace be unto you all. Welcome to this lecture series. So, first of all, the disclaimer. This is an independent educational video for medical students. I am not affiliated with the authors or publishers of this textbook. We will be reviewing high yield concepts based on standard medical textbooks like Master the Boards, authored by Dr. Conrad Fisher. For complete details, please refer to the original textbook. Today, we are starting with part 1, Internal Medicine, chapter 1, that is Gastroenterology. In this series, we will cover every key point and concept from the chapter, ensuring nothing important gets left behind. What makes this different from other lectures out there? First, it's a fast yet complete review. You will get the whole gastroenterology chapter in just one or two sittings, focused, high yield, and to the point. Second, it's beginner friendly. If you are new, this will help you make sense of GI concepts and see how things connect. You can always go deeper into resources later. Third, if you have already studied medicine, this works as a rapid revision before rounds, wards, or exams. And fourth, if you are preparing for exams like FCPS, NLE, NEET PG, USMLE, PLAB, or other national international competitive exams, this will help you revise the entire chapter efficiently under time pressure. So, whether you are starting fresh or revising, this lecture will give you clarity, structure, and speed. This video is for educational purposes only and does not replace your own reading of standard textbooks. Let's dive into gastroenterology. Esophageal disorders. So, first of all, there are these two terminologies, dysphagia and odynophagia. There is a subtle difference between the two. Dysphagia is difficulty in swallowing, while odynophagia is pain while swallowing. Dysphagia is the essential feature of most esophageal disorders. Alarm symptoms include blood in stool, anemia, and weight loss. So, blood in stool, anemia, and weight loss are the alarm symptoms. If any of these symptoms are present, perform an endoscopy to exclude cancer. So, blood in stool, anemia, and weight loss. If any of these are present, do endoscopy. Weight loss has, by the way, limited value when diagnosing an esophageal disorder, since it is seen in both dysphagia and odynophagia. Hiatal hernia, as the name indicates, it is a protrusion of the upper part of the stomach into the chest, generally caused by obesity, weakening of the diaphragm. It is associated with heartburn, chest pain, and dysphagia. And that is the reason that it is not so easily distinguishable from GERD, because these symptoms can be, you know, there in the patients of GERD as well, in the gastroesophageal reflux disorders, heartburn, chest pain, and dysphagia. So symptoms can be indistinguishable from GERD. Diagnosis is made by endoscopy or barium study. Let's see the diagram. So here is the diagram of a normal person, a normal healthy person, and here is the diagram of a patient having sliding hiatal hernia. So this is esophagus, has the diaphragm, the esophageal hiatus, lower esophageal sphincter, and stomach. And in this diagram you see the lower esophageal sphincter has come out of the esophageal hiatus and it lies above the normal level of lower esophageal sphincter. And there is a hernia, there is a protrusion of the upper part of the stomach into the chest, and that's what we call is hiatal hernia. The best initial treatment is weight loss and PPIs, proton pump inhibitors. If symptoms persist, proceed with surgical correction. So the surgical correction and the option that we've got is Nissen fundoplication. We will go into further detail of Nissen fundoplication in the surgery section, but for now, Nissen fundoplication is the gold standard surgery for GERD that does not respond to medications. Basically, quote unquote, a rape to stop acid reflux. So how it works? So the surgeon takes the upper part of your stomach called the fundus and wraps it 360 degrees around the lower esophagus. This tightens the lower esophageal sphincter so acid can't flow back up, but food can still go down. There is this another point that paraesophageal hernia is more likely to need surgery than gastric volvulus, obstruction, strangulation, and perforation. Now let's talk about achalasia. Achalasia is the inability of the lower esophageal sphincter to relax due to a loss of nerve plexus within the lower esophagus. The etiology is not clear. There is aperistalsis of the esophageal body. So achalasia is basically inability of the lower esophageal sphincter to relax. How do you diagnose it? So look for these things. Look for a young patient aged less than 50 years with progressive dysphagia to both solids and liquids at the same time. This is very much important. Remember, the dysphagia will be progressive in nature. It will be to both solids and liquids, and it will be to both solids and liquids at the same time. And there will be no association with alcohol or tobacco use. Diagnostic testing includes barium esophagram, which will show a bird's beak as the esophagus comes down to a point. Here is the achalasia from inadequate relaxation of the lower esophageal sphincter. Note the narrowing at the end of the esophagus on barium study. Manometry is the most accurate test. It will show a failure of the lower esophageal sphincter to relax. There are these other options as well, that is chest x-ray and upper endoscopy. Chest x-ray may show some abnormal widening of the esophagus, but the thing is that chest x-ray is neither very sensitive nor very specific. Upper endoscopy shows normal mucosa because the main problem in achalasia is with the nerve plexus. There is a loss of the nerve plexus within the lower esophagus. The mucosa is normal. However, endoscopy is useful to exclude what? Malignancy. So in the esophagus, barium studies are acceptable to do first in most patients, although radiologic tests always lack the specificity of endoscopic procedures. Treatment is simple mechanical dilation of the esophagus. There is no real quote-unquote cure. That is, nothing can restore the normal function of the missing neurological control of the esophagus. Yet, these are the treatment options that we've got. Number one is pneumatic dilation, which is highly effective. Pneumatic dilation is basically placement of an endoscope that will allow a device to be inflated, which will enlarge the esophagus. But the point is, in less than 3% of the patients, this treatment will cause perforation. So what is pneumatic dilation? It is basically placement of an endoscope that will allow a device to be inflated. So it's a kind of enlargement of the esophagus by the help of inflation via a device through the help of a placement of an endoscope. It is safer than surgery but slightly less effective. That's the reason that choosing between the two procedures may be difficult. Second option is surgical sectioning or myotomy to alleviate symptoms. Third one is botulinum toxin injection to relax the lower esophageal sphincter. However, the effects wear off in 3 to 6 months, requiring re-injection. So you have to re-inject the botulinum toxin every 3 to 6 months. The moment the effects of the injection wear off, you have to do it again and again and again every 3 to 6 months. So it requires re-injection. There is this important point that you all should note, that in the esophagus only cancer and Barrett esophagus are diagnosed by biopsy. We don't necessarily need biopsy for the other problems of esophagus, but the cancer and the Barrett esophagus are diagnosed by biopsy. Now let's talk about esophageal cancer. So what you should look for in the scenarios which ask you about what is the most likely diagnosis. If the answer to that question is esophageal cancer, so you should look for these things. The age is usually equal to or more than 50 of the patient that is having esophageal cancer. There is the problem of the symptom of dysphagia, but the thing is that first it is for solids only, followed later progressing to dysphagia for liquids. And this is the difference between the symptom that we discussed above in achalasia. So there was a progressive dysphagia to both solids and liquids at the same time. And here in esophageal cancer, the dysphagia is first for solids only, followed later progressing to dysphagia for liquids. Association with prolonged alcohol and tobacco use. That is also another distinguishing point of esophageal cancer from what? From the achalasia, which is not associated usually with alcohol or tobacco use. So, and also look for more than 5 to 10 years of GERD symptoms, gastroesophageal reflux disorder symptoms. The single word, note it down, the single word progressive or from solids to liquids is the most important clue to the diagnosis of esophageal cancer. Remember that. Diagnostic testing is as follows. Endoscopy is indispensable, since only a biopsy can diagnose cancer. We already studied that point. Barium might be the best initial test, but no radiologic test can diagnose cancer. It's just that the barium studies is the best initial test that we've got. But the final diagnosis will be made through biopsy, and that needs endoscopy. CT and MRI to determine the extent of spread into the surrounding tissues. They are not enough to diagnose esophageal cancer. PET scan to determine the contents of anatomical lesions if uncertain. Whether they contain cancer, often used to determine whether a cancer is resectable. That is done by PET scan. For cancer, the radiologic test is never the most accurate test. Second point, local disease is resectable, removable, but widely metastatic disease is not because it has already metastasized extensively. Treatment is surgical resection. No resection is equal to no cure. In addition, chemotherapy and radiations are used, but these are used in addition. The main treatment is the surgical resection. For lesions that cannot be resected, stent placement can keep the esophagus open for palliation and to improve dysphagia. So, if there are lesions that cannot be resected easily, so you can place the stent that will keep the esophagus open for palliation and to improve the problem of dysphagia. Now let's talk about esophageal spasm. There are two forms of spastic disorders, that is diffuse esophageal spasm and nutcracker esophagus. These are the two forms of spastic disorders: diffuse esophageal spasm, DES, and nutcracker esophagus. So these two forms are clinically indistinguishable. Both present with the sudden onset of chest pain unrelated to exertion. Initially, it is impossible to distinguish them from an atypical coronary spasm or unstable angina. So the symptoms include that it is precipitated by drinking cold liquids. It is sudden in nature and severe in nature. So it causes a sudden severe chest pain. When you do the EKG, it comes out to be normal. The stress tests are normal. And the esophagram is also normal, as well as the endoscopy is clear. So how do you diagnose them then? So the diagnosis of DES, that is diffuse esophageal spasm, and nutcracker esophagus, and distinguishing them is done with manometry. That is the most accurate test, which shows a different pattern of abnormal contraction in each. So when you do manometry and when you go for manometry, it shows a different pattern of abnormal contraction in each. Here is the depiction and pictorial presentation of esophageal spasm as revealed by barium study, which shows a corkscrew appearance at the time of the spasm. So here you can see the corkscrew appearance which appears there at the time of the spasm. So this is the pictorial presentation of what? Esophageal spasm. Treatment of esophageal spastic disorders is as follows. CCBs, calcium channel blockers. And try TCAs like tricyclic antidepressants are an alternative. If those fail, you can go for sildenafil. Nitrates, similar to treatment of Prinzmetal angina, and PPIs, proton pump inhibitors in some cases. So this was all about esophageal spasm. Once again, there are two forms of spastic disorders as far as the esophageal spasm is concerned: diffuse esophageal spasm DES and nutcracker esophagus. So clinically both of them are indistinguishable from one another, and both present with sudden onset of chest pain unrelated to exertion, and the symptoms include that it is precipitated by drinking cold liquids. It causes sudden severe chest pain. The EKG and stress are normal. Esophagram and endoscopy is normal. Then you go for manometry, and it is the most accurate test which shows a different pattern of abnormal contraction in each of them. And here is what the depiction of esophageal spasm. What is the treatment? Treatment is CCBs. Tricyclic antidepressants are an alternative. If those fail, go for sildenafil. Nitrates, similar to treatment of Prinzmetal angina, and PPIs, proton pump inhibitors in some cases. So here is this main point that you should remember, that whether DES or nutcracker esophagus, both of them present with sudden onset of chest pain, but it is unrelated to exertion. This is where you get the clue that this pain, this chest pain, is not of cardiac origin necessarily. And also, obviously, you have to go for the other investigations as well, like EKG, stress test, esophagram, and endoscopy. Eosinophilic esophagitis. Patients with eosinophilic esophagitis have swallowing difficulty, food impaction, and heartburn. Look for a history of asthma and allergic diseases, because patients with such allergies tend to develop eosinophilic esophagitis. Endoscopy shows multiple concentric rings like these. This is the pictorial presentation of eosinophilic esophagitis. You can see the multiple concentric rings. The most accurate test is what? Biopsy finding eosinophils. So you would go for biopsy, and the finding of that biopsy will show the presence of eosinophils. That will give you a clue that it is eosinophilic esophagitis. The best treatment is PPIs and the elimination of allergenic foods that is causing the production and the increase of eosinophils in esophagus. So try to avoid those foods that you are allergic to that is causing this problem, and also use PPIs. If no response, then you can go for steroid inhalers. So swallowing steroid inhalers will allow for the topical use of steroids. So the best initial treatment is PPIs and the elimination of allergenic foods. If there is no response, then you can go for swallowing steroid inhalers. So it will act as topical steroids. It will allow for the topical use of steroids on those areas, on the affected areas. Infectious esophagitis. A 43-year-old man recently diagnosed with AIDS come to the ED emergency department with pain on swallowing that has become progressively worse over recent weeks. There is pain only when swallowing. CD4 count is 43 mm cube. The patient is not currently taking any medications. What is the most appropriate next step in management? So there are these options: esophagram, upper endoscopy, oral nystatin swish and swallow, intravenous amphotericin, oral fluconazole. So the best answer is oral fluconazole. The most appropriate next step in management is giving oral fluconazole. So it is a 43-year-old man which is recently diagnosed with AIDS. He is experiencing pain on swallowing, progressively worse over recent weeks. CD4 count is 43 and he is not currently taking any medications. So the most commonly asked infectious esophagitis question is about esophageal candidiasis in a person with AIDS. So oral candidiasis, that is thrush, need not to be present in esophageal candidiasis. One does not automatically follow from the other. Although other infections such as CMV, cytomegalovirus, and herpes can also cause esophageal infections. More than 90% of esophageal infections in patients with AIDS are caused by Candida. Empiric therapy with fluconazole is the best course of action. If that does not help perform an endoscopy, nystatin treats oral candidiasis. The oral swish and swallow form is not sufficient to control esophageal candidiasis. IV amphotericin is used for confirmed candidiasis that has not responded to fluconazole. So this is a kind of summary of how you deal with such kind of questions. So the thing is that the patient is not having any oral candidiasis. So it is important to note that oral candidiasis need not to be present in esophageal candidiasis. One does not automatically follow from the other. Like in this patient, there is no complaint of oral candidiasis, but there is the presence of esophageal candidiasis. And the other thing that he says is that although other infections such as CMV and herpes can also cause esophageal infection, more than 90% of esophageal infections in patients with AIDS are caused by Candida. So that is based upon the medical knowledge. You have to understand it, that a patient who is diagnosed with AIDS and is having a problem of pain on swallowing, odynophagia. So in more than 90% of esophageal infections like this one, the infectious esophagitis in this patient is caused by who? By Candida, that is fungi. So now you have to give treatment according to this scenario. So the best next step in management is empiric therapy with fluconazole. Empiric therapy with fluconazole. Why not oral nystatin? It's because it only treats oral candidiasis. It's not sufficient to control the esophageal candidiasis. True. And why not upper endoscopy? We would go for the best step or the most appropriate next step in management. Although we go for upper endoscopy, but that is only opted after we see that the oral fluconazole is not working or the patient symptoms are not responding to the empiric therapy with fluconazole. Only then we perform an endoscopy. And how about intravenous amphotericin? So remember, the question says what is the most appropriate next step in management? We can give IV amphotericin once the candidiasis is confirmed and that the candidiasis has not responded to the oral fluconazole. Only then we will go for the option of the intravenous amphotericin. So the right option we've got is oral fluconazole. The following pills cause esophagitis if in prolonged contact. So you have to remember these medications: doxycycline, alendronate, potassium chloride. Doxycycline, alendronate, and potassium chloride. So these pills cause esophagitis if used in a longer duration, if in prolonged contact. Now look at this chart. Dysphagia, if there is a problem of dysphagia like difficulty in swallowing with HIV where the CD4 count is less than 100, if this is the case, then empirically start fluconazole. Like in this case, the CD4 count was less than 100, there was progressive dysphagia, and the patient was diagnosed with AIDS. What do? We start empiric treatment with fluconazole. Now, if there comes some improvement, we continue the therapy and add antiretroviral therapy as well. But if there is no improvement, we perform upper endoscopy with biopsy in order to check what the real problem is. So if the biopsy finding shows the presence of large ulcerations, it means it is caused by CMV. The infectious esophagitis. In such cases, we already studied that in more than 90% of esophageal infections in such patients which are diagnosed with AIDS are caused by Candida, but there is a chance, a fair chance, that it might also be caused by CMV or herpes. So when you start the empiric treatment with fluconazole and it does not improve the symptoms, you perform upper endoscopy with biopsy. If the biopsy shows large ulcerations, it means that it is caused by CMV. If it shows small ulcerations, it means it is HSV. So if CMV is the result, the therapy is ganciclovir or foscarnet. And in case of small ulcerations that is caused by HSV, the therapy is acyclovir. So it is the entire management of infectious esophagitis. Now let's talk about different kinds of rings and webs. Shortsky ring and Plummer-Vinson syndrome both cause dysphagia. So both present with the problem of dysphagia. Shortsky ring is often caused by acid reflux, associated with hiatal hernia, a type of scarring or tightening, peptic stricture of the distal esophagus. So it is associated with hiatal hernia, associated with intermittent dysphagia. How about the Plummer-Vinson syndrome? Plummer-Vinson syndrome is associated with iron deficiency anemia, can rarely transform into squamous cell cancer. Iron deficiency not caused by blood loss. So when you see such patients, there will be iron deficiency anemia, but that iron deficiency anemia will not be due to some kind of blood loss. All of the other things will be completely normal, yet the patient will be having iron deficiency anemia. So it means that it indicates that it might be from the Plummer-Vinson syndrome. It is also more proximal than the Schatzki ring. Rings are easily detected on barium studies of the esophagus. So this was the difference. Schatzki ring is often caused by acid reflux associated with a hiatal hernia, and it is associated with intermittent dysphagia, while the Plummer-Vinson syndrome is associated with iron deficiency anemia, can rarely transform into squamous cell cancer, and the iron deficiency is not caused by blood loss. It is more proximal than Schatzki, and they are easily detected on barium studies of the esophagus. Treatment is as follows: Schatzki ring and Plummer-Vinson syndrome. So for Schatzki ring, we do pneumatic dilation, the same procedure that we opted in the achalasia. So it is an endoscopic procedure where you dilate the esophagus through the help of a device which is put there with the help of endoscopy, and then you through the mechanical pressure dilate it. While in Plummer-Vinson syndrome, iron replacement at first is the treatment, which may lead to resolution of the lesion. So this is the treatment options. For Schatzki ring, it is pneumatic dilation. For Plummer-Vinson syndrome, it is iron replacement at first, which may lead to resolution of the lesion. Stackhouse syndrome is dysphagia from solid food associated with Schatzki ring. So what is Stackhouse syndrome? Stackhouse syndrome is basically dysphagia from solid food. Why do we get it? Because it has got association with Schatzki ring. Here is the pictorial depiction of the Schatzki ring, visible on barium study as a distal narrowing of the esophagus, and that's the distinguishing point from the Plummer-Vinson syndrome as well, because Plummer-Vinson syndrome rings are usually more proximal than Schatzki. Zenker diverticulum. Zenker is an outpocketing of the posterior pharyngeal constrictor muscles. Symptoms include dysphagia, severe halitosis, bad breath and bad smell, regurgitation of food particles, aspiration pneumonia when contents of the diverticulum end up in the lung. It can also cause aspiration pneumonia. Diagnostic testing is barium study. Repair is made with surgery. There is no medical treatment because there is a structural problem out there, which is outpocketing of the posterior pharyngeal constrictor muscles. Here is the tip. So there is what? There is no medical treatment. Surgery is a gold standard. Do not answer nasogastric tube placement or upper endoscopy. These are dangerous to people with Zenker diverticulum and may cause perforation. So do not answer NG tube placement or upper endoscopy, because these are dangerous to the people with Zenker diverticulum. It can cause perforation. Scleroderma. Scleroderma patients present with symptoms of reflux and have a clear history of scleroderma or progressive systemic sclerosis. So these are skin conditions that we will discuss in the dermatology section in detail. But for now, scleroderma patients present with symptoms of reflux and have a clear history of scleroderma or progressive systemic sclerosis. Manometry shows decreased lower esophageal sphincter pressure from an inability to close the LES, lower esophageal sphincter. Treatment is PPIs. The disorder is simply one of the mechanical immobility of esophagus. Manometry is the answer for achalasia, spasm, and scleroderma. If you remember, we just studied all of them. Manometry is the answer for achalasia, esophageal spasms, and scleroderma. Malarious tear. Malarious tear presents with upper GI bleeding after prolonged or severe vomiting or retching. Repeated retching is followed by hematemesis, that is the presence of blood in the vomitus. So hematemesis of bright red blood, or by black stool, because it is upper GI bleed and it can present as melena, represented by black stool. So, and also there is no dysphagia. So in malarious tear there is upper GI bleed and it is caused by a prolonged severe vomiting or retching. So the repeated retching is then followed by hematemesis, that is the presence of bright red blood in the vomitus, or it can also present in the form of black stool, which indicates melena, which indicates in turn the upper GI bleed. But there is no complaint of dysphagia. There is no specific treatment and it will resolve spontaneously. It will heal spontaneously. For severe cases with persistent bleeding, epinephrine injection or electrocautery can stop the bleeding. So you have to intervene if the bleeding is persistent and is not stopping. So go for the epinephrine injection or electrocautery to stop the bleed. So what's Boerhaave syndrome? So there is this subtle difference between the malarious tear, it's just a tear, and then we have got Boerhaave syndrome, which is full penetration of the esophagus. So this is a large tear, and malarious is a non-penetrating tear of only the mucosa, while the Boerhaave syndrome, it involves the entire full penetration of the esophagus. Epigastric pain. The epigastric area is the part of the abdominal surface located just beneath the xiphoid process and between the two sets of ribs. It is above the umbilicus. So, what is epigastric area and where is it located? So, epigastric area is the part of the abdominal surface located just beneath the xiphoid process. So, the xiphoid process in the thorax that can easily be palpable. So, just beneath the xiphoid process, the part of the abdominal surface is called epigastric area. So, just beneath the xiphoid process and between the two sets of ribs. this is what we call as the epigastric area, but it is above the umbilicus. So now epigastric pain in the epigastric area is common. Up to 25% of the population at some point in their lives experience the epigastric pain. Tenderness. What is tenderness? It is far less common, but what is it? So it is basically an increased pain on palpation or pressure in the epigastric area. So when you palpate or put some pressure on the epigastric area and it causes increase in the pain, it means that there is tenderness in that area. So tenderness is basically a general terminology used for increased pain on palpation or pressure. It can be in any area, but here epigastric pain is experienced up to 25% of the population at some time in their lives, while tenderness is far less common. Pain and tenderness. Pain is basically a complaint or sensation that is stated by the patient. Is not the same thing as tenderness. Tenderness is a physical finding on examination. So when you go for the abdominal examination, you find the tenderness, but when it is uttered by and when the patient presents with the complaint on sensation, it is pain. So it is not the same thing as tenderness. Tenderness is something different from pain. Here is the MCQ. A 44-year-old woman comes in reporting pain in the epigastric area for several months. She denies nausea, vomiting, weight loss, and blood in the stool. On physical examination, no abnormalities are found. What is most likely diagnosis? Duodenal ulcer disease, gastric ulcer disease, gastritis, pancreatitis, functional dyspepsia, pancreatic cancer. So let's discuss the answer. In the hospital, you will see far more patients with ulcer disease, pancreatic disorders, or cancer, because those are the ones who are admitted. However, functional dyspepsia, that is non-ulcer dyspepsia, is by far the most common cause of epigastric pain. 50 to 90% of all cases, especially age less than 60, with the problem of the epigastric pain are due to functional dyspepsia, that is the non-ulcer dyspepsia. Functional dyspepsia is virtually never a reason to be admitted to a hospital. So the answer is E, functional dyspepsia. You see, the patient, when the physical examination is done, you don't see any further abnormalities. So that's what gives you a clue that it might be functional dyspepsia, and also it is more common. So 50 to 90% of all cases, especially age less than 60, like this woman who is 44 years old and is reporting pain in epigastric area, but she denies everything else which is important, like nausea, vomiting, weight loss, blood in the stool. So it is not due to some ulcer, it is not due to some malignancy, because in malignancy we notice and report weight loss, if there is some blood in stool, GI bleed, vomiting, So all of these are significant in such scenarios. But if the woman denies all these things, so we can go for the functional dyspepsia. So epigastric pain, if you asked about the epigastric pain, how to answer the questions of what is the most likely diagnosis, here is the chart. If this is in the history, the most likely diagnosis is these. If the pain was with food, in 70% cases, such patients are having gastric ulcer. If the pain gets better with food in 70% of the patients, it denotes duodenal ulcer. This is the main difference between the gastric ulcer and duodenal ulcer. The pain gets worse with food in gastric ulcer and it gets better with food in duodenal ulcer. If there is weight loss, significant weight loss, it can be due to cancer, malignancy, or gastric ulcer. Maybe the patient is not eating very well due to the problem of gastric ulcer. Tenderness, if there is some tenderness, it can denote pancreatitis. Bad taste, cough, hoarse. So these symptoms indicate that the patient might be having GERD. Diabetes and bloating, if these two are there in the history, it may be gastroparesis, because the emptying of the stomach content gets slowed in the diabetic patients due to the autonomic neuropathy, and it causes problems like flatulence, bloating, etc. If the history contains none of these, it means that it is non-ulcer dyspepsia, which is out there in 50 to 90% of all cases, especially in age less than 60. So that's what we call as functional dyspepsia. Patients hospitalized with epigastric pain are far more likely to have ulcers, biliary disease, pancreatic disease, cancer, and gastritis with bleeding, because we just said here that functional dyspepsia is virtually never a reason to be admitted to hospital. So if you see somebody with a problem of epigastric pain and he or she is hospitalized, so think about it, that she or he more likely they are having ulcers along with it, or biliary disease, pancreatic disease, cancer, gastritis with bleeding, etc. Diagnostic tests. Endoscopy is the only way to truly understand the etiology of epigastric pain from ulcer disease. Radiologic and barium testing are modest in accuracy at best. You cannot biopsy with the radiologic testing. We are saying it again and again. So the precise diagnosis can only be given by endoscopy. Here is the tip. In the esophagus, barium study is a good place to start with testing. But in stomach, barium is very poor. So in esophagus, barium study is a good place to start with testing. But in stomach, barium is very poor. So here is the chart which shows the causes of abdominal pain by location. So this is right upper quadrant, and this is left upper quadrant, this is left lower quadrant, this is right lower quadrant. So you divide the entire abdomen in 4 quadrants. In the right upper quadrant, if there is the complaint of pain in this location and site, it indicates that it might be caused by cholecystitis, biliary colic, cholangitis, or perforated duodenal ulcer. If it is in the left upper quadrant, it may be due to splenic rupture or IBS, splenic flexure syndrome. If it is in the right lower quadrant, it might be due to, but I would say most commonly be due to appendicitis if the other symptoms are along with it, or ovarian torsion in females, ectopic pregnancy in females, cecal diverticulitis. So all of these can present as right lower quadrant pain. The pain may be different in nature, but all of them present with right lower quadrant pain. Appendicitis, ovarian torsion, ectopic pregnancy, cecal diverticulitis. Left lower quadrant, sigmoid volvulus, sigmoid diverticulitis, ovarian torsion, because ovaries are on the both sides. So ovarian torsion can present as right lower quadrant pain and as well as lower quadrant, left lower quadrant pain. Also, ectopic pregnancy is common in both of them. Treatment of epigastric pain start with PPIs. The various medications all have equal efficacy. Additionally, H2 blockers and liquid antacids. So H2 blockers like nizatidine, cimetidine, famotidine are less effective but work in about 70% of patients. So the best treatment is PPIs. Start with the PPIs. But additionally, you can give H2 blockers as well. And along with it, the liquid antacids. Same efficacy as H2 blockers. Less effective but work in about 70% of patients. Misoprostol. Okay, so here is this location as well, mid-epigastrium. So what if the pain is in the mid-epigastrium? It can be caused by pancreatitis, aortic dissection, peptic ulcer disease. But you have to look for the other symptoms associated with these problems accordingly. And we will discuss them one by one in different chapters. Misoprostol is always a wrong answer. Misoprostol, an artificial prostaglandin analog. Misoprostol is an artificial prostaglandin analog. So it was designed to prevent NSAID-induced gastric damage. When PPIs arrived, misoprostol became obsolete and a wrong answer on the test. Because nowadays we use PPIs for that purpose. And you might be thinking that this book is not focusing too much on dosing. It's because it is mainly written for step 2 CK, and USMLE step 2 CK does not test dosing. That's right. GERD, gastroesophageal reflux disease. So GERD is the inappropriate relaxation of the lower esophageal sphincter, causing the acid contents of the stomach to come up into the esophagus. Symptoms of GERD are worsened by nicotine, alcohol, caffeine, chocolate, peppermint, late night meals, and obesity. So the symptoms of GERD are worsened by nicotine, alcohol, caffeine, chocolate, peppermint, late night meals, and obesity. There are no unique physical findings in GERD. It is a symptom complex most often diagnosed based on patient history. When the diagnosis is not clear, 24-hour pH monitoring may be considered to confirm the etiology. So when the diagnosis is not clear, 24-hour pH monitoring may be considered to confirm the etiology. Symptoms include sore throat, bad taste in the mouth, kind of metallic taste, hoarseness in the voice or cough. So GERD may also show redness, erosions, ulcerations, strictures, or esophagus if it persists for a longer period of time. What is the most likely diagnosis? So GERD is the answer when you see epigastric burning pain radiating up into the chest. It is usually epigastric and burning pain in nature, and it is radiating up into the chest. You do not have to have all of these extra symptoms present in order to answer. GERD is the most likely diagnosis. This is the most important point that you all need to remember. This is an MCQ. Stay with me. A 42-year-old man comes to the office with several weeks of epigastric pain radiating up under his chest, which becomes worse after lying flat for an hour. He also has a brackish taste in his mouth and a sore throat. See, all of the symptoms that we studied, this patient is experiencing then. What is the next step in management? What is your answer? So the answer is lansoprazole, a PPI, proton pump inhibitor. And why is lansoprazole the next step in management? So let's discuss it and break it down simply. Lansoprazole is a PPI that should be used to control the symptoms of GERD. When the diagnosis is very clear, such as in this case, with epigastric pain going under the sternum, bad taste, or throat, confirmatory testing is not necessary, because it is the typical presentation of the GERD symptoms. H2 blockers are effective in 70% of the patients but are clearly inferior to PPIs. See? So that's the reason that we don't go for ranitidine as a next step in the management, because they're clearly inferior to the PPIs. Endoscopy does not diagnose GERD and is certainly not necessary when the diagnosis is so clear. So that's why endoscopy is also the wrong answer here. Barium swallow shows major anatomic abnormalities of the esophagus and is worthless in GERD. So, for example, in cases of achalasia or some other structural abnormalities, anatomic abnormalities that were there in the esophagus, we would go for barium swallow, but not here in the cases of GERD. So the best answer and the right answer is lansoprazole. Endoscopy will show nothing when there is only pyrosis. Okay. What will endoscopy show? It will show nothing if there is only pyrosis, that is the symptom of heartburn. Endoscopy is indicated when there is, so this is the important discussion that we are about to discuss. Endoscopy is indicated when there is what? Signs of obstruction such as dysphagia or odynophagia. Either there is difficulty in swallowing or there is pain while swallowing. So in such cases we go for endoscopy, because these are the signs of obstruction, or weight loss, which is usually associated with problems like malignancies and cancers. So in order to rule out those things, you have to go for endoscopy. Or anemia or heme positive stools. For example, anemia is associated with iron deficiency, anemia is associated with Plummer-Vinson syndrome and all those things. Heme positive stools in cases of some malignancy, or in cases of some um, Borhaus syndrome, or in cases of Miller-Weiss tears. Treatment starts with lifestyle management. So lose weight if obese. Avoid alcohol, nicotine, caffeine, chocolate, mint, because these are the things that aggravates the GERD symptoms. Avoid eating within 3 hours of bedtime. So avoid late night eating. Elevate head of bed 6 to 8 inches in order to alleviate the GERD symptoms, in order to alleviate the acid reflux. So you have to elevate head of bed 6 to 8 inches. Additionally, for mild or intermittent symptoms, liquid antacids or H2 blockers are preferred. For persistent symptoms or erosive esophagitis, PPIs, all of the PPIs are equally effective for persistent symptoms or erosive esophagitis. How about symptoms if they are unresponsive to treatment? For example, in 5% of the cases, then you go for surgical or anatomic correction to tighten the lower esophageal sphincter, and we discussed this option of Nissen fundoplication. So Nissen fundoplication is basically the wrapping of the stomach, upper part of the stomach, around the lower esophageal sphincter in order to tighten it, so that the acid in the stomach cannot flow back up. There is this another option of endokinch, using a scope to place a suture around the lower esophageal sphincter to tighten it. So it is also done with the help of endoscopy. You can give local heat or radiation to the lower esophageal sphincter, which will cause scarring, and it will then not relax so easily in order to get the acids out of the stomach into the esophagus. So these are the options. If the symptoms are not getting better with time, and the problem still persists, and it is unresponsive to the treatment, to the meds, to the medications, to the liquid antacids, H2 blockers, PPIs, which usually happens in 5% of the cases, then you go for the surgical anatomic correction, Nissen fundoplication or endokinch, or local heat or radiation of LES. Barrett esophagus. Long-standing GERD leads to histologic changes in the lower esophagus with columnar metaplasia. So when there is GERD and it becomes a long-standing one, it can bring about histological changes in the lower esophagus. So with columnar metaplasia, with a different kind of histology. So columnar metaplasia usually needs at least 5 years of reflux to develop, and there are no unique physical findings or lab tests. Only endoscopy can determine the presence of Barrett esophagus, because the endoscopy will give us a clue about the columnar metaplasia. You know how? Biopsy is the only way to be certain of the presence of Barrett esophagus or dysplasia, metaplasia. This is indispensable because the biopsy drives treatment. It is the biopsy that would tell us whether the histology is columnar or otherwise. Columnar metaplasia with intestinal features has the greatest risk of transforming into the esophageal cancer. So usually and normally the intestinal features, the columnar metaplasia with intestinal features is there in the intestine, but here the normal histology is changed due to the long-standing GERD, and the histological changes brought about columnar metaplasia, which usually needs at least 5 years of reflux to develop. And this columnar metaplasia with intestinal features has the greatest risk of transforming into esophageal cancer. Each year, about 0.5% of people with Barrett esophagus progress to esophageal cancer. So, Barrett esophagus is the result of a long-standing GERD, and then each year about 0.5% of people with Barrett esophagus progress to esophageal cancer. Here are the findings and the management accordingly. So if there is Barrett alone, that is metaplasia only, PPIs and rescope every 3 to 5 years. If low grade dysplasia is there, PPIs and rescope every 6 to 12 months in order to check whether it's really transforming into esophageal cancer. So we have to rescope every 6 to 12 months, not every 3 to 5 years, because there is now a bigger chance of its transformation to esophageal cancer. And how about high grade dysphagia? So you go for ablation with endoscopy, photodynamic therapy, radiofrequency ablation, and endoscopic mucosal resection. So you go for the removal of the root problem, and that's how you do it. So it was all about the findings and management. Now let's talk about the gastritis. Gastritis, sometimes called gastropathy, is inflammation. Let's revise this management plan once again. So, what did we discuss? These are the findings, and along with it is the management portion given accordingly. So, if the finding shows that there is Barrett alone, there is only metaplasia, you go for PPIs and rescope 3 to 5 years. If it is a low grade dysplasia, then PPIs and rescope every 6 to 12 months. If there is a high grade dysplasia, you go for ablation with the endoscopy. So endoscopic ablation is basically using an endoscope to deliver energy that destroys abnormal tissue inside the GI tract. No surgical cuts. So all done through the mouth or anus with a scope. For example, in such cases. So the precancerous lining in lower esophagus are actually ablated in these cases, and because it prevents esophageal adenocarcinoma to develop. Now let's start gastritis. Gastritis, sometimes called gastropathy, is inflammation or erosion of the gastric lining. Causes include alcohol, NSAIDs, Helicobacter pylori, H. pylori, portal hypertension, stress such as burns, trauma, sepsis, and multi-organ failure, MOF, for example, uremia. Atrophic gastritis is associated with vitamin B12 deficiency. Atrophic gastritis. Atrophic gastritis is associated with vitamin B12 deficiency. So these are the points you have to remember. Gastritis, sometimes called gastropathy, is basic inflammation or erosion of the gastric lining. Causes include alcohol, NSAIDs, Helicobacter pylori, portal hypertension, and stress such as burns. It is very much important to remember the burn point and the trauma, sepsis, and multi-organ failure. What is the most likely diagnosis? Gastritis often presents with GI bleeding without pain. Severe erosive gastritis can present with epigastric pain. NSAIDs or alcoholism in the history is a clue. So usually it presents with GI bleeding but without pain. But in case of severe erosive gastritis, it can also present with epigastric pain. NSAIDs or alcoholism in the history is a clue. The GI bleeding can range from a mild coffee ground emesis, that is mild coffee ground colored vomitus, to a large volume vomiting of red blood to a black stool, melena. So as it counts as upper GI bleed, so it can either present as a mild coffee ground emesis or a large volume vomiting of red blood, or it can also present as a black stool, which is also called melena. For gastritis, you cannot answer the most likely diagnosis question from the history and physical alone. There are no unique physical findings for gastritis. Here are manifestations and volume of bleeding. So, when the volume of the bleed is about 5 to 10 ml, it often presents as coffee ground emesis. If it is 5 to 10 ml, it can present as heme positive stool. If it is 50 to 100 ml volume of bleed, then it presents as melena, which is visible through normal eyesight. You don't have to test it, it's just visible right away. Correlation of manifestations with volume of bleeding. Diagnostic tests. So only upper endoscopy can definitively diagnose erosive gastritis. In order to check for the erosions caused by gastritis, you have to do upper endoscopy. Capsule endoscopy is not appropriate for upper GI bleeding if endoscopy is one of the choices. Testing for H. pylori, that is Helicobacter pylori, should also be performed because it would require treatment, which is the triple therapy. You have to go for H. pylori stool antigen, HPSA, in order to test for Helicobacter pylori and then treat it accordingly if the test shows positive results for it. Although anemia may occur, there are no specific blood tests. Radiologic studies such as an upper GI series will not be specific enough. So the best option, the best diagnostic test is upper endoscopy. It will definitively diagnose erosive gastritis. So anemia may occur. Why does anemia occur in such patients? Because of the blood loss. Now, here is the testing for H. pylori. So this is the test column. What is good about this test and what is bad about this test. So we've got these multiple options for testing for Helicobacter pylori. Endoscopic biopsy. It is the most accurate of all the tests, and it is the good thing about this test. Endoscopic biopsy. But it requires an invasive procedure such as endoscopy. This is the bad thing about this test. Serology, inexpensive, easily exclude infection of easily excludes infection if it is negative. So it is a good thing that it is not expensive, and also it excludes infection if it comes out to be negative. But the problem is that this test lacks specificity. A positive test does not easily tell the difference between current and previous infection. Rarely, right? This is the problem. It lacks specificity. So if the test comes out to be positive, it does not easily tell the difference between current and previous infection, whether the infection is still present or it is just gone and it was a previous infection. This is the bad thing about the serology option. Urea C13 or C14 breath testing. Now, positive only in active infection, 95% sensitive and specific. But the problem is that it requires expensive equipment in office. The good thing about it is 95% sensitive and specific. The bad thing about it is it requires expensive equipment in office, and also that it is positive only in active infection. So if it turns out to be positive, it means that there is an active infection going on due to Helicobacter pylori. The last one is H. pylori stool antigen, HPSA. It is positive only in active infection, same as urea C13 or 14 breath testing. It is also 95% sensitive and specific, same as urea C13 or C14 breath testing. And the bad thing that they say is that it requires the stool sample. But I think it's not that much bad thing about the test. You have to do something in order to test for it, so it's the best option. H. pylori stool antigen test. It requires a stool sample and it is positive only in active infection, 95% sensitive and specific. What are the treatment options? So treatment is PPIs. H2 blockers, sucralfate and liquid antacids are not as effective. So you have to give what? You have to give PPI for gastritis. Sucralfate is an inert substance, usually an aluminum hydroxide complex, that coats the stomach. If sucralfate is presented as an answer choice on the exam, it is nearly always the wrong answer. Maltoma causes a false negative H. pylori stool antigen. So if there is maltoma, it can cause a false negative H. pylori stool antigen. We will discuss maltoma in detail later on. Stress ulcer prophylaxis is indicated in mechanical ventilation, burns, head trauma, coagulopathy. So when do you opt for prophylaxis for stress ulcer? So it is indicated in mechanical ventilation, in cases of burns, head trauma, and coagulopathy. Peptic ulcer disease. Peptic ulcer disease includes duodenal ulcer and gastric ulcer disease. Causes include, the most common cause is Helicobacter pylori. Second most common cause is NSAIDs. So peptic ulcer disease is basically an umbrella term which includes duodenal ulcer and gastric ulcer disease. The most common cause is Helicobacter pylori. The second most common cause is NSAIDs. Why do NSAIDs cause peptic ulcer disease? It is due to their effect in inhibiting the production of protective mucus barrier in the stomach. So the NSAIDs inhibit prostaglandins, and prostaglandins produce the mucus. So NSAIDs produce more bleeding than pain. You know why? Because it inhibits the production of the protective mucus barrier in the stomach. So it inhibits the production of the protective mucus barrier, and the mucosa of the stomach gets exposed to the harsh environment of the stomach acids. Burns, head trauma. These are also causes of peptic ulcer disease, Crohn disease, gastric cancer, gastrinoma, for example, Zollinger-Ellison syndrome, but all of them are less common. You have to remember these two. The most common one is Helicobacter pylori. The second most common one is NSAIDs. The name peptic ulcer disease is a misnomer based on the mistaken belief that the conditions were caused by the protein digesting enzyme pepsin. That's why they were called peptic ulcer disease. Anyhow, it's the umbrella term used for both of these disorders, duodenal ulcer and gastric ulcer disease. Here is the tip. Alcohol and tobacco do not cause ulcers. They delay the healing of ulcers. This is very much important point. So they do not cause ulcers themselves, but they just delay the healing process of ulcers. What is the most likely diagnosis? Peptic ulcer disease presents with recurrent episodes of epigastric pain that is described as dull, sore, and gnawing. Although the most common cause of upper GI bleeding is PUD, peptic ulcer disease, the majority of those with ulcers do not bleed. Tenderness and vomiting are unusual. So, here is the point. PUD presents with recurrent episodes of epigastric pain. So, the pain is dull, sore, and gnawing in nature. Here is another point. Most common cause of upper GI bleed is PUD. There is no doubt about it. But the majority of those with ulcer do not bleed at all, and tenderness and vomiting are unusual in PUD. So you cannot answer PUD is the most likely diagnosis based on symptoms alone. There is no way to diagnose PUD without endoscopy or barium studies. You have to go for them. There is no way to distinguish DU, GU, duodenal ulcer, gastric ulcer, gastritis, and non-ulcer dyspepsia without endoscopy. You can't just distinguish between these scenarios based on symptoms alone. So you have to go for the endoscopy. Changes in pain with eating are not specific enough to make a diagnosis of DU versus GU. So you can say that in 70% of the cases, as we just studied, that if the pain is there right after meal and it gets worse after meal, then we can say, so if the pain gets worse with food, in 70% cases it is gastric ulcer, and pain gets better with food, in 70% cases it is duodenal ulcer. But it's not always the case, and you can just decide based on these symptoms alone. So changes in pain with eating are not specific enough to make a diagnosis of duodenal ulcer versus gastric ulcer. Testing includes upper endoscopy, most accurate test to distinguish DU and GU. In those who are to undergo endoscopy, there is no point in doing non-invasive testing, such as serology, breath testing, or stool antigen detection. So they don't need to go for non-invasive testing if they are already ready to undergo endoscopy. Because upper endoscopy is the most accurate test to distinguish between DU and GU. Endoscopy is the only method for detecting gastric cancer. Cancer is present in 4% of those with GU but in none of those with DU. So, patients with gastric ulcer, 4% of them has got gastric cancer as well. But in the patients with a DU, you will see no such thing. Radiologic testing, for example, upper GI series to detect ulcers but cannot detect cancer or H. pylori. So, the radiologic testing will only detect the ulcers. H. pylori testing, so as we studied that biopsy is the most accurate test. It's the good thing about the endoscopic biopsy, but it requires an invasive procedure such as endoscopy. That's the bad thing about it. But the most accurate one is what? Biopsy. There is no doubt about it. Treatment is as follows. For PUD, peptic ulcer disease, PPIs, effective in far majority of cases but will recur unless H. pylori is eradicated. So you have to eradicate H. pylori along with it because the symptoms will recur unless H. pylori is eradicated completely. Duodenal ulcer is associated with H. pylori in more than 80 to 90% of the cases. GU is associated with H. pylori in 50 to 70% of the cases. For H. pylori, you have to give triple therapy. So one PPIs plus 2 antibiotics. PPIs plus 2 antibiotics. As far as the 2 antibiotics are concerned, clarithromycin and amoxicillin is preferred. If no response, metronidazole, levofloxacin, or tetracycline are alternatives. Note, this is the only use of tetracycline. So, the triple therapy contains PPIs plus 2 antibiotics. There are 2 antibiotics, clarithromycin and amoxicillin are usually preferred. Clarithromycin and amoxicillin. One is macrolide, clarithromycin, and amoxicillin is penicillin. So those are preferred. If no response, you can go for metronidazole, levofloxacin, or tetracycline. So those are the alternatives to them. Adding bismuth to a change of antibiotics may help to resolve treatment-resistant ulcers. Retest with stool antigen or breath test to confirm the eradication of Helicobacter. And repeat endoscopy for those with GU to exclude cancer. As we said, that in 4% of those with GU, they have cancer as well, the gastric cancer. So if treatment is started and the patient with GU are not getting better, we have to repeat the endoscopy to exclude cancer as a reason for not getting better. Previous clarithromycin use for other reasons give 30% failure in its use to treat H. pylori. That's the reason that doctors often say do not self-prescribe the antibiotics. It's because it develops AMR, antimicrobial resistance. So previous clarithromycin use for other reasons give 30% failure in its use for treatment of H. pylori. The only way to exclude cancer is with biopsy. This is an important point. You can test for H. pylori with non-invasive methods and treat it. But you cannot exclude gastric cancer non-invasively. This is the point. Don't treat asymptomatic Helicobacter. If It is not causing problems. Do not treat it. So here is the Helicobacter pylori treatment in peptic ulcer disease. If the biopsy is positive for H. pylori and the person is not allergic to penicillins, give PPI, clarithromycin and amoxicillin, triple therapy. If the patient is allergic to penicillin, replace the amoxicillin with metronidazole, and then 30 to 60 day post therapy testing for eradication is done. Once the treatment is started, 30 to 60 day post therapy testing for eradication of H. pylori is usually done. Here is the MCQ. A 56-year-old woman comes to the clinic because her symptoms of epigastric pain from an endoscopically confirmed duodenal ulcer have not responded to several weeks of a PPI, clarithromycin, and amoxicillin. What is the most appropriate next step in management? So, the duodenal ulcer is confirmed through endoscopy. The patient have not responded even after several weeks to PPI, clarithromycin, and amoxicillin, and the symptoms persist. So, what is the most appropriate next step in management? If there is no response to duodenal ulcer therapy with PPI, clarithromycin, and amoxicillin, the first thought should be antibiotic resistance. See, the first thought should be antibiotic resistance of the organism. Persistent H. pylori infection can be detected with urea breath testing, stool antigen detection, or a repeat endoscopy for biopsy. All of them are the options to detect H. pylori. It would be very hard to choose between these, and that is why they are not all given as choices in the question, because all of them can be used in order to detect H. pylori. Capsule endoscopy cannot detect H. pylori. See, H2 blockers and sucralfate add nothing to a PPI and have less efficacy, not more. You have to remember that. So, there is no need for surgery, and there is no need to switching PPI to switching PPI to H2 blockers, because H2 blockers add nothing to a PPI. They are inferior to PPIs. There is no need of abdominal CT. Capsule endoscopy cannot detect H. pylori. No need to add sucralfate, ogotomy. Urea breath testing is the right option in order to check for the H. pylori. So it is the most appropriate next step in management. Treatment failure most often stems from bacterial resistance is the first reason. Non-adherence to medication. If the patient is not showing compliance, alcohol, tobacco, NSAIDs. Now let's talk about the stress ulcer prophylaxis only with head trauma, burns, intubated patients, sepsis with coagulopathy. We already studied that once. It's the second time. So stress ulcer prophylaxis only in the cases of head trauma, burns, intubated patient, sepsis with coagulopathy. Functional non-ulcer dyspepsia. This is an important topic. Functional non-ulcer dyspepsia is epigastric pain that has no identified etiology. It can only be diagnosed after endoscopy. The pain of the non-ulcer dyspepsia can be identical to gastritis, PUD, gastric cancer, reflux disease. So it's basically and epigastric pain with a normal endoscopy. And ANUD is the most common cause of epigastric pain, a functional dyspepsia. Treatment is as follows. In age less than 60, treat empirically with anti-secretory therapy such as PPI, and scope only if symptoms do not resolve. So you don't need to do endoscopy directly. If age is more than 60, endoscopy is definitely indicated to exclude cancer, because cancer becomes frequent in the patients with such symptoms and having the age more than 60. Non-ulcer dyspepsia is not definitely associated with H. pylori. However, if symptoms do not resolve with initial therapy and H. pylori is present, you should try to treat it. Symptoms persist plus H. pylori present, then go for treatment of H. pylori. Scope for dyspepsia. If patient is age more than 60, it is alarming. So alarm symptoms are present: dysphagia, weight loss, anemia. We studied this in the very beginning. If these alarm symptoms, that is dysphagia, weight loss, anemia, are present and the patient is above 60 years of age, or PPI fails to control the symptoms, go for scope, go for endoscopy. So scope for dyspepsia only if these things are present. In the case of non-ulcer dyspepsia, functional dyspepsia. Gastrinoma, Zollinger-Ellison syndrome. Less than 1% of those with ulcer disease have a gastrinoma. So gastrinoma is often associated with diarrhea because acid inactivates lipase. And if the lipase is inactivated, it causes diarrhea. What is the most likely diagnosis? Look for a patient with ulcers that are large, more than 1 to 2 cm, recurrent after Helicobacter eradication, distal in the duodenum, multiple. Once endoscopy confirms the presence of an ulcer, the most accurate diagnostic tests include. So once it is confirmed that there is an ulcer that is present through endoscopy, then the most accurate diagnostic tests include what? Lab testing. Any of the following will confirm the diagnosis. So high gastrin level of anti-secretory therapy. High gastrin level despite a high gastric acid output. Persistent high gastrin level despite injecting secretin. So it indicates that there is gastrinoma that is continuously producing high levels of gastrin despite a high gastric acid output, despite injecting secretin. This was the first option. Second is imaging. Once diagnosis has been confirmed to exclude metastatic disease, you go for imaging. So to exclude metastatic disease, imaging is the best option to go for. Abdominal CT MRI is done first but has poor sensitivity. That is, a negative test does not exclude metastasis. If CT MRI is normal, somatostatin receptor scintigraphy. So it is basically a nuclear octreotide scan is combined with endoscopic ultrasound to exclude metastatic disease. So The first option is abdominal CT or MRI is done, but it has poor sensitivity. That is, it means that a negative test does not include metastasis. So if CT-MRI is normal, somatostatin receptor scintigraphy, somatostatin receptor scintigraphy. So somatostatin receptor scintigraphy, that is a nuclear octreotide scan, is combined with endoscopic ultrasound to exclude metastatic disease. The most accurate test is always a functional test, such as looking at the response to secretin. This is the most accurate test. So, hypercalcemia is the clue for multiple endocrine neoplasia. Men. Multiple endocrine neoplasia. So, hypercalcemia is the clue for it. So, when there is this problem called men from hyperparathyroidism, hypercalcemia will be there because of hyperparathyroidism. Gastrinoma is associated with a massive increase in the number of somatostatin receptors in the abdomen. Local disease is removed surgically. Metastatic disease is unresectable and is treated with lifelong PPIs to block acid production. Diabetic gastroparesis. So, long-standing diabetes leads to gastric dysmotility. Gastric dysmotility. Distension of the stomach and intestines is normally the most important stimulant to motility. Gastroparesis is an autonomic neuropathy leading to dysmotility. So it causes problems with the normal physiologic motility of the gut because of the autonomic neuropathy caused by an inability to sense stretch in the GI tract. That's the reason that it causes dysmotility, and the emptying of the stomach becomes slow, and the distension of the stomach and intestines occur. What is the most likely diagnosis? Look for diabetic patient with chronic abdominal discomfort, bloating, constipation. There is also anorexia, nausea, vomiting, and early satiety. So the patient does not usually crave for food. There is nausea and vomiting and early satiety, early fullness. So a 64-year-old patient with diabetes for 20 years comes to the office with several months of abdominal fullness, intermittent nausea, constipation, sense of bloating. On a physical examination, a splash is heard over the stomach on auscultation of the stomach. When moving the patient, what is the most appropriate next step in management? So, let's discuss and break it apart in order to understand it simply. So, when the diagnosis of diabetic gastroparesis seems clear, there is no need to do diagnostic testing unless there is a failure of therapy. Okay, so no further diagnostic testing should be done. Erythromycin or metoclopramide increases gastrointestinal motility. The most accurate test for diabetic gastroparesis is the nuclear gastric emptying study, although it is rarely needed. From the symptoms alone, you can guess that it is gastroparesis, and it is confirmed and it is clear as bright as daylight. So now there is no need to do diagnostic testing unless there is a failure of therapy. So abdominal CT scan, colonoscopy, upper endoscopy, nuclear gastric emptying study is done for the confirmation of the diabetic gastroparesis is a most accurate test for it. but we don't need to do it because it is very much clear that the patient is having diabetic gastroparesis. So we would go directly for the treatment option, that is erythromycin. Metoclopramide is another alternative. Metoclopramide. Since diabetes can also be associated with GERD and diarrhea, confirmatory testing may be needed. So, best initial test, most accurate test. Upper endoscopy or abdominal CT to exclude a luminal gastric mass or an abdominal mass compressing the stomach. So this is the best initial test for what? Diabetic gastroparesis, because diabetes can also be associated with GERD and diarrhea. So we need confirmatory testing. So for confirmatory testing, the best initial test is upper endoscopy or abdominal CT to exclude a luminal gastric mass or an abdominal mass compressing the stomach. Most accurate test is bolus of food tagged with technetium, a nuclear isotope. So a delay in the emptying of food indicates gastroparesis. It's easy. It's the most accurate test. Treatment starts with dietary modification, blenderized foods, restored foods, and corrected potassium and glucose levels. Here is where the, the treatment starts. You have to correct the potassium and glucose levels, use the blenderized foods and the fluids, restored fluids. If no response to dietary modification, start metoclopramide. This will induce tardive dyskinesia, dystonia, and movement disorder in 1% of the patients. So it is the side effect of the metoclopramide, but it usually happens in only 1% of the patients. Other adverse effects are long QT and hyperprolactinemia. So it increases the level of prolactin in the blood and it causes QT to prolong. So these are the adverse effects: long QT on ECG and hyperprolactinemia. And in 1% of the patients, these very much serious problems can occur. It can induce tardive dyskinesia, dystonia, and movement disorders. So if metoclopramide is ineffective, answer erythromycin and antiemetics. If all medical treatment fails, do gastric electrical stimulation with the help of a gastric pacemaker. So it will not need the autonomic nervous system that much in order to keep the food moving, keep the gut moving in a healthy manner. So a gastric pacemaker will cause the gastric electrical stimulation and it will somehow relieve the symptoms. So metoclopramide cannot be used permanently because dystonia and hyperprolactinemia will develop. Now let's come to the gastrointestinal bleeding. Gastrointestinal bleeding, upper and lower GI bleeds arise from two general groups of etiologies. So it depends upon the location. So location, upper, lower, most common cause and other causes. So upper GI bleed ulcer disease, and lower GI bleed is most common cause is diverticulosis. Other causes of upper GI bleed contains esophagitis, gastritis, cancer, duodenitis, varices. While in the lower GI bleed, other causes besides the most common cause, that is diverticulosis, the other causes include angiodysplasia, polyps, IBD, inflammatory bowel disease, cancer, and even upper GI bleeding and hemorrhoids. This is the etiology of gastrointestinal bleeding. Here is the MCQ. A 69-year-old woman comes to the ED with multiple red black stools. Remember, over the last day. Her medical history is significant for aortic stenosis. Her pulse is 115 per minute and blood pressure is 94 by 62. 94 systolic, 62 diastolic. Physical examination is otherwise normal. What is the most appropriate next step in management? So let's break it down. Identifying the etiology of several GI bleed is not as important as giving fluid resuscitation. There is no point in checking for orthostasis with the patient's systolic BP less than 100 mmHg or when there is tachycardia at rest. Endoscopy should be performed but not as a first step. When BP is low, normal saline or linger lactate are better fluids to give than 5% dextrose in water. So 5% dextrose in water, that is D5W, does not stay in the vascular space to raise BP as well as NS. This is very much important. So the patient here is having a BP, a blood pressure of 94 by 62, that is quite low. So the main thing here that is important is not that we should identify the etiology of the severe bleed. It's not as important as giving fluid resuscitation. There is no point in checking for orthostasis with the patient's systolic BP less than 100 mmHg or when there is tachycardia at rest. So these are the options that we should go for. The bolus of 5% dextrose in water, bolus of normal saline. But now between these two, see, when BP is low, normal saline or ringer lactate are better fluids to give than 5% dextrose in water. So always go for normal saline or ringer lactate. So D5W does not stay in the vascular space to raise BP as well as normal saline. So the final answer is D, bolus of normal saline. Addressing BP is the most important initial management for GI bleed. Important to note. Ischemic colitis. Older patients with a history of DM, hypertension and vascular disease are susceptible to ischemic colitis. It presents with left lower quadrant pain, mucosal friability on scope, and a clear demarcation between ischemic and normal tissue. It spares the rectum. So now let's start talking about the ischemic colitis. So older patients with a history of DM, diabetes mellitus, hypertension, and vascular disease are susceptible to ischemic colitis. It presents with left lower quadrant pain, left lower quadrant pain, mucosal friability and scope, and a clear demarcation between ischemic and normal tissue. So it will be clearly demarcated on endoscopy, and there will be mucosal friability on endoscopy, and the pain is there in the left lower quadrant pain, and it is Often the complaint in the older patients who have a history of diabetes mellitus, hypertension, vascular disease, they are the ones who are susceptible to ischemic colitis. But the main thing is that it spares the rectum. It does not involve the rectum. The condition is not life-threatening and bleeding resolves without specific treatment. Physical symptoms include orthostasis. So, orthostasis is basically more than 10-point rise in pulse when going from lying down to sitting, standing, or more than 20-point drop in systolic BP when sitting up. This is the problem. So you can say that the physical symptom orthostasis is there if only there is more than 10% rise in pulse when going from lying down to sitting or standing position. If a person is lying and you make him or her sit or stand, and the pulse rise of that patient is more than 10 point, and it means that there is orthostasis. Or in terms of systolic BP, if there is equal to or more than 20 point systolic BP drop when sitting up, it is also considered to be orthostasis. So if a person is lying down and you make him or her sit up and the systolic BP drops by more than 20 points, it means that it is orthostasis. So orthostasis is there in the ischemic colitis. Variceal bleeding, only form of GI bleed in which physical examination helps determine etiology. So this is variceal bleeding. So it is the only form of GI bleed in which physical examination helps determine etiology. The presence of the signs of liver disease helps establish the diagnosis. So it is related with the variceal bleed. Suspect variceal bleed when symptoms include vomiting, plus minus black stool, it is melena, spider angioimata, and caput medusa. So these are the problems that often occur when we have liver problems, portal hypertension, and stuff like this. So suspect variceal bleed when symptoms include vomiting, plus minus black stools, spider angioimata, and caput medusa, splenomegaly, palmar erythema, and or hysterexis. So it is important to note all of it. Physical findings, orthostasis. So percentage of blood loss. If 15 to 20% of the entire blood is lost, the physical finding will show orthostasis. If 30% is lost, the pulse rate will be more than 100 per minute. Or if it is 30% lost, the systolic BP, the systolic blood pressure will be less than 100 mmHg. So this is how you correlate the physical finding with the percentage of blood loss in ischemic colitis. If it is 15 to 20%, it will show orthostasis. If it is 30%, it will either show pulse rate of more than 100 per minute or systolic BP less than 100 mmHg. So severity of blood loss based on hemodynamics. Initial management of GI bleeding is not based on the etiology. It is based on the severity. This is important. For acute bleeding, especially when severe, it is far more important to replace fluids, check the hematocrit, platelets, and run coagulation tests such as PT or INR than it is to do an endoscopy. It is important to check for the cause of the bleed. But in acute settings, for example, in acute bleeding, especially when it is severe, it's not that much important. The first most priority that we must prioritize is to replace the fluids, check the hematocrit platelets, and run coagulation tests, PT or INR. We will deal with the cause of the bleed later on. That's why uh, it is important to note that the initial management of GI bleeding is not based on the etiology, it is based on the severity. Diagnostic testing is with the NG tube, but this has limited benefit. There is no treatment to be delivered through the NG tube, but it can guide where to start with endoscopy. So it's not for the therapeutic purposes, it's for the diagnostic purpose. If upper endoscopy will be done anyway, NG tube has a limited role. About 10% of those with red blood from the rectum have high volume upper GI bleeding with rapid transit time. So about 10% of those with red blood from the rectum have high volume upper GI bleeding with rapid transit time. The sensitivity of the NG tube is 70% if you see bile in the aspirate. However, then you know the NG tube aspirate really is more than 95% sensitive. This is an extra important point. If the stool is black in a person with cirrhosis, but there is no hematemesis, that is blood in the vomiting or in the vomitus. If the stool is black in a person with cirrhosis, but there is no hematemesis, and NG tube showing red blood may tell you to use octreotide for varices and arrange urgent endoscopy for possible bending of varices. Is the point. Test and indication: nuclear bleeding scan, angiography, capsule endoscopy. So, when is nuclear bleeding scan indicated? Endoscopy unrevealing in a massive acute hemorrhage lacks accuracy. So, if there is acute hemorrhage and it is massive in amount, so endoscopy can be unrevealing. It cannot reveal the things which we are looking for because of the acute massive hemorrhage. So it lacks accuracy. In such cases, nuclear bleeding scan is then indicated. How about angiography? So specific vessel or site of bleeding needs to be identified prior to surgery or embolization of the vessel, used only in massive non-responsive bleeding. So if there is a specific vessel or site of bleed that needs to be identified prior to surgery, or that needs embolization of that particular vessel, so in such cases you have to go for angiography because it is used only in massive non-responsive bleeding. Okay. Capsule endoscopy, small bowel bleeding. Upper and lower endoscopy do not show the etiology. So when is it indicated? When there is small bowel bleeding and upper and lower endoscopy do not show the etiology, then you go for the capsule endoscopy. When do you go for angiography? So angiography is indicated when a specific vessel or site of bleeding needs to be identified prior to surgery or embolization of the vessel. So in cases of massive non-responsive bleeding, you have to go for the angiography. And when to go for the nuclear bleeding scan? It is indicated when the endoscopy is unrevealing due to massive acute hemorrhage. So we go for the nuclear bleeding scan. And how about CT or MRI of abdomen or EKG, lactate levels, etc. So CT or MRI of abdomen is not useful in GI bleeding. And EKG lactate level shows ischemia in severe bleeding. See, so electrocardiography and lactate levels. It shows ischemia and severe bleeding. This is the only significance of these tests. So these were the additional diagnostic tests for GI bleeding. 80% of GI bleeding will stop spontaneously if the fluid resuscitation is adequate. This is the point. That's why we focus more on the fluid resuscitation than finding out the exact cause of that particular GI bleed. Most patients die of inadequate fluid replacement. This is the problem. And in 80% of GI bleed will stop spontaneously if the fluid resuscitation is adequate. Treatment is as follows. Fluid replacement with high volumes 1 to 2 liters per hour of saline or ringer lactate in those with acute severe bleeding. 1 to 2 liters per hour should be administered of normal saline or ringer lactate with acute severe massive hemorrhages or bleeding. Packed RBCs. If hematocrit is less than 30, if patient is older or suffers from coronary artery disease, if patient is young, transfusion may not be needed until the hematocrit is very low. So in older patients, if hematocrit is less than 30, go for packed red blood cells. Or if he suffers from if the patient is suffering from coronary artery disease, still if the hematocrit count is less than 30, go for packed RBCs. But if the patient is young, transfusion may not be needed until the hematocrit is very low, that is less than 20 to 25%. So first option or the first treatment is fluid replacement. Then check the hematocrit. If the hematocrit is less than 30 and the patient is older or the patient suffers from CAD, go for packed RBCs. And if it is young and the hematocrit is less than 20 to 25, then go for packed RBCs. Fresh frozen plasma. If the PT or INR is elevated and active bleeding is occurring, go for FFP. Platelets, if less than 50,000 and there is bleeding along with it, then go for platelets. Reversal of anticoagulants. Andexanet alpha reverses 10A inhibitors, XA inhibitors. For example, rivaroxaban, apixaban, and edoxaban. So if the bleeding is due to the anticoagulants, so you have to reverse the effects of the anticoagulants by giving andexanet alpha. Andexanet alpha reverses XA inhibitors, rivaroxaban, apixaban, edoxaban. And adalimumab reverses dabigatran, and prothrombin complex concentrate PCC reverses warfarin. So if the bleeding is due to the use of anticoagulants, if the patient has taken anticoagulants, one of the XA inhibitors, that is rivaroxaban, apixaban, and edoxaban, you go for andexanet alpha. And if it is due to the use of dabigatran, you go for adalimumab. And if it is due to the warfarin, you have to reverse its effect by using PCC, prothrombin complex concentrate. Endoscopy to determine the diagnosis and administer some treatment. For example, so it is diagnostic and therapeutic at the same time in this scenario. Therapeutic in a sense that it is used for some treatments like band varices, cauterized ulcers, inject epinephrine into bleeding, gastric vessels. You can go for IV PPI for upper GI bleed. Surgery to remove the sites of bleeding if fluids, blood, platelets, and plasma will not control the bleeding. So at the last resort, you go for surgery. Here is the tip. Platelets are transfused when count is less than 50,000 per microliter and there is active bleeding. This is the important point you have to note. You would not transfuse platelets to prevent a spontaneous bleed unless the count was much lower. That is less than 10,000 to 20,000. So there's a difference. If there is an active bleed and the count of platelets is less than 50,000, go for transfusion, platelet transfusion. But if it is not active bleed, it is a spontaneous bleed, then you don't have to transfuse platelets unless the count is much lower, that is less than 10 to 20,000. Esophageal and gastric varices. What do you do in addition to administering fluids, platelets, and plasma? So, esophageal and gastric varices. What do you do in addition to administering fluids, blood, platelets, and plasma? So, octreotide is, you can say, is a synthetic somatostatin. It decreases portal pressure. Bending performed by endoscopy obliterates esophageal varices. Transjugular intrahepatic portosystemic shunting TIPS is used to decrease portal pressure in those who are not controlled by octreotide and bending. Propranolol and nadolol is used to prevent subsequent episodes of bleeding. Beta blockers such as propranolol will not do anything for the current episode of bleeding. It's just used for the prevention of the subsequent episodes. Antibiotics to prevent spontaneous bacterial peritonitis (SBP). So, if ascites is present. Similarly, Blakemore tube or balloon tamponade is rarely used as temporary measure before TIPS procedure. Balloon tamponade. Sclerotherapy is never the right answer if bending is technically possible. So let's read it again. What do you do in addition to administering fluids, blood, platelets, and plasma? So we do the octreotide option. Octreotide is a synthetic somatostatin which will decrease the portal pressure. We do bending performed through endoscopy. It will obliterate esophageal varices. Similarly, TIPS is another option, transjugular intrahepatic portosystemic shunting. It also decreases portal pressure in those who are not controlled by octreotide and bending. So this is the third option. And we can also use the beta blockers such as propranolol or nadolol. They can't stop the current bleed, but they can prevent subsequent episodes of bleeding. Antibiotics in order to prevent the SBP, spontaneous bacterial peritonitis, if ascites is present. You can also go for Blakemore tube or balloon tamponade. And also, sclerotherapy is never the right answer if bending is technically possible. Here comes the diarrhea topic. Diarrhea. So, antibiotic associated diarrhea. Although clindamycin may be associated with the highest incidence of antibiotic associated diarrhea, and C. difficile, any antibiotic can potentially cause diarrhea. Blood and white blood cells may be present in the stool. It usually presents several days or weeks after the start of antibiotics. So it is important to note that even though we know that clindamycin is usually associated with the highest incidence of antibiotic associated diarrhea and C. difficile, but any antibiotic in reality can potentially cause diarrhea. Blood and white blood cells may be present in the stool. It usually presents several days or weeks after the start of antibiotics. The best initial test is a stool C. difficile toxin test. The most accurate test is PCR or N-double-18-night. So best initial is going for the stool C. difficile toxin test, and the most accurate is PCR or NET. What is the treatment option? Treatment is oral vancomycin, most effective initial therapy. Oral vancomycin. If there is no response, switch to hydroxymycin. So oral vancomycin is the best, most effective initial therapy. If there is no response, switch to hydroxymycin. For a patient with positive C. difficile stool toxin but no symptoms, there is no treatment needed. This is important. The treatment is given only if there are symptoms along with the positive C. difficile stool toxin. So without having any sort of symptoms related to the antibiotic associated diarrhea, just having a positive C. difficile stool toxin test does not give you a way to go for the treatment. It is not needed. So a 75-year-old man is admitted to the hospital with pneumonia. Several days after the start of antibiotics, he begins to have diarrhea. The stool C difficile toxin is positive, and he started on vancomycin, which resolves the diarrhea after a few days. 2 weeks later, the diarrhea recurs and the C. diff toxin is again positive. What is the most appropriate next step in management? So it was a 75-year-old man admitted to the hospital with pneumonia, and for pneumonia, as he started the antibiotics, he began to have diarrhea. So what is the most appropriate next step in management? The answer is B. You know why? Because recurrent episodes of C. difficile associated diarrhea are best treated with another course of vancomycin. Intravenous metronidazole is used only if oral therapy cannot be used, such as in patients with an adynamic ileus. So the patients of adynamic ileus, you can't give oral therapy, so then you can go for the intravenous metronidazole. Stool is never cultured for C. difficile because it simply will not grow in culture. Endoscopy looking for pseudomembranes will diagnose antibiotic associated diarrhea, but is not a necessary step given the availability of stool toxin assay. So the stool toxin assay is already positive, so you don't need to go for endoscopy. The best option is retreat with vancomycin. Intravenous vancomycin is always wrong for antibiotic associated diarrhea since it will not pass the bowel wall. This is important, and that's the reason we go for the oral vancomycin. So it is always wrong for antibiotic associated diarrhea since it will not pass the bowel wall. So what is fulminant C. difficile? Fulminant C. difficile is when there is high WBC more than 15,000, WBC count is more than 15,000, metabolic acidosis is there, high lactate is there, high creatinine is there. So 1.5 times of the baseline cret. If it's high that much and the WBC count is more than 15,000, metabolic acidosis there, high lactate is there, it's what is called as fulminant C. difficile. Several considerations come to play in the treatment of C. difficile. See, both vancomycin and fedoximicin have better efficacy than metronidazole, but vancomycin is preferred. Vancomycin is less expensive than fedoximicin. This is another good thing about vancomycin. So, if vancomycin is preferred but cannot be given orally, it can be given by enema, because we have to in some way reach the vancomycin dose into the gut, and that's the reason we give oral vancomycin and we don't go for the intravenous vancomycin, because it will not pass the bowel wall then. So if vancomycin is preferred and but cannot be given orally, go for the enema option. So if there is a recurrence after vancomycin, give a tapered dose of vancomycin. So for the recurrent, if it's recurring, go for the option of retreating with the vancomycin. After multiple recurrences, use bezlotoxumab or do fecal transplantation. So if the recurrences get multiple, and after multiple recurrences you have to use bezlotoxumab or do fecal transplantation. Bezlotoxumab is actually an antibody against C. difficile toxin. For fulminant life-threatening infection, use vancomycin plus metronidazole. And for fulminant difficile, we already discussed. It's a life-threatening infection, but it has to complete the criteria, that is high WBC more than 15,000, high grade 1.5 times of the baseline, metabolic acidosis, high lactate levels, and you have to give vancomycin plus metronidazole both to treat it. And after multiple recurrences, if it's not fulminant and it's just occurring again and again and again, use bezlotoxumab, which is an antibody against C. difficile toxins, or do fecal transplantation in order to avoid this recurrence problem. Here is the tip. Switching to fedoximicin is the answer when the case does not respond to vancomycin. So here is the antibiotic associated diarrhea algorithm. Diarrhea after antibiotic use. If there is diarrhea after antibiotic use, then check for whether C. difficile is positive or not. If C. difficile is positive, then treat with vancomycin. If the improvement comes along the way, then continue vancomycin until end of the course. If there is no improvement with the vancomycin, then switch to fedoximicin. And again, look at the C. difficile positivity. If there is no C. difficile, then consider alternative causes. It's not due to this. Once again, diarrhea after antibiotic use. If the patient gets diarrhea after the use of antibiotics, go for C. difficile positive testing, whether it's positive or negative. If it's negative, consider alternative causes. If it's positive, start treating it with vancomycin and look for the improvement. If the improvement happens, go for the continuation of the vancomycin therapy until the end of the course. If there is no improvement, switch to fedoximicin. Malabsorption. Celiac disease is one of the most common types of malabsorption and can present as an adult. Chronic pancreatitis has a very similar presentation with fat malabsorption. Rare causes of fat malabsorption are tropical sprue and Whipple disease. All of these present with steatorrhea. Steatorrhea is basically an oily, greasy stool due to the high levels of fat in the stool. So such stool is called steatorrhea. So it's defined as stool that is oily, greasy, floating, and foul smelling. And it is associated with all kinds of malabsorption. So all of these present with steatorrhea. Celiac disease is one of the most common types of malabsorption, can present as an adult. Chronic pancreatitis has a very similar presentation with fat malabsorption, and rare causes of fat malabsorptions are tropical sprue, Whipple's disease. You can go and check first aid for it. All of these things are written over there, or any other pathology book. As we are discussing medicine, so we won't go into detail in each one of them. Celiac disease is associated with thyroiditis, vitiligo, pernicious anemia, type 1 diabetes. So remember these associations of celiac disease. All forms of fat malabsorption present with deficiency of fat-soluble vitamins such as A, D, E, K. Because if there is fat malabsorption, there will be deficiency of fat-soluble vitamins as well. So all of the deficiencies can happen and manifest themselves. Vitamin D deficiency can cause hypocalcemia, osteoporosis. Vitamin K deficiency can cause bleeding, easy bruising. Vitamin B12 deficiency can cause anemia, hypersegmented neutrophils, and neuropathy. So these are the manifestations according to the deficiencies. Here is the tip. Fat malabsorption frequently presents with weight loss. Vitamin B12 needs an intact bowel wall and pancreatic enzymes to be absorbed. It's not a fat soluble vitamin, but it needs an intact bowel wall. So in cases of malabsorptions where the bowel wall is not intact and pancreatic enzymes are not working properly, so vitamin B12 can also be deficient. Presentation. There is nothing clinically to distinguish tropical sprue from celiac disease, that is gluten sensitive enteropathy. So clinically they are indistinguishable. Celiac disease gives dermatitis herpetiformis in 10% of cases. This is the extra manifestation of the celiac disease. It is associated in 10% of the cases with dermatitis herpetiformis. Whipple disease also presents with arthralgias, ocular findings, neurologic abnormalities, dementia, seizures, fever, lymphadenopathy, that is the swelling of the swollen lymph nodes. Treat with ceftriaxone followed by trimethoprim sulfamethoxazole. So the celiac disease association is with thyroiditis, vitiligo, pernicious anemia, type 1 diabetes, while the Whipple disease can also present with arthralgias, ocular findings, neurologic abnormalities, fever, lymphadenopathy. Treat with ceftriaxone followed by TMP-SMX. Okay, so diagnostic tests. One of the main distinctions between chronic pancreatitis and gluten sensitive enteropathy is the presence of iron deficiency. This is a very much important point. This is because iron needs an intact bowel wall to be absorbed but does not need pancreatic enzymes to be absorbed. So, one of the main distinctions between chronic pancreatitis and gluten sensitive enteropathy is the presence of iron deficiency. So, in chronic pancreatitis, the problem is in the pancreatic enzymes, and the bowel wall is intact. But in gluten sensitive enteropathy, the intact bowel wall is not present, so the bowel wall is not intact. And the iron needs an intact bowel wall to be absorbed but does not need pancreatic enzymes to be absorbed. So, in chronic pancreatitis, there will be no iron deficiency in the patient, while in sensitive enteropathy, gluten sensitive enteropathy, it is celiac disease where where there is no intact bowel wall, we will be having iron deficiency. So this is one of the distinguishing point. Unique test for celiac disease. So TTG test, a test is usually done is the first test. Anti-tissue transglutaminase, anti-TTG. So it can be falsely negative in IgA deficiency. So a negative result does not mean there is no celiac disease present. It can be falsely negative in IgA deficiency. So anti-TTG is the first test, anti-tissue transglutaminase. Second is anti-endomysial antibody. Third one is IgA antigliadin antibody. Rice and wine are safe in celiac disease. So you just have to avoid the gluten containing products like wheat, etc. Rice is safe. Wine is also safe in celiac disease. The most accurate diagnostic test for celiac disease is small bowel biopsy. This is the most accurate diagnostic test that shows flattening of the villi. Whipple disease and tropical sprawl are also most accurately diagnosed with a bowel wall biopsy, showing the specific organism. So the biopsy will show flattening of the villi in the case of celiac disease. Bowel biopsy is essential in celiac disease to exclude lymphoma. To exclude lymphoma. Chronic pancreatitis. Diagnostic testing includes abdominal X-ray 50 to 60% sensitive for calcification of the pancreas. Abdominal X-ray 50 to 60% sensitive for calcification of the pancreas. Abdominal CT is 80 to 90% sensitive for pancreatic calcification. MRCP or EUS with secretin enhancement is more accurate than CT scan. So secretin stimulation test is the most accurate test. Place a NG tube, administer an IV injection of secretin. A normal pancreas will release a large volume of bicarbonate-rich fluids. The abdominal X-ray is very specific for chronic pancreatitis when the test is abnormal. Okay, so it is very specific. but it has got a low sensitivity. If the abdominal X-ray is showing that the test is abnormal, then it is specific for chronic pancreatitis. The angiotensin receptor blocker olmesartan gives a sprue-like illness. So here are the calcifications shown on the X-ray. So chronic pancreatitis leads to calcification of the pancreas visible on X-ray in 50 to 60% of the patients. Its sensitivity is 50 to 60%, but it's quite specific. If an imaging is showing a positive finding like this, then it is definitely a case of chronic pancreatitis. This is the difference between specificity and sensitivity. Here is the CT. Abdominal CT scan has greater sensitivity and specificity in the detection of calcifications of the pancreas. These whites are the calcifications that are taken through abdominal CT scan. The Dees-Allos test is an old test that distinguished pancreatitis from bowel wall abnormalities. Dees-Allos test results are normal in pancreatic disorders too. It was just used back in the days to distinguish between pancreatitis and bowel wall abnormalities. So Dees-Allos test results are normal in pancreatic disorders. This is all what you need to remember. Disease and specific treatment. Chronic pancreatitis, celiac disease, Whipple's disease, tropical sprue. So chronic pancreatitis requires enzyme replacement because due to the chronic pancreatitis, enzymes are not being released normally, and there is this problem of malabsorption due to it. Celiac disease, avoid gluten containing foods such as wheat, oats, rye, or barley. So wheat, oats, rye, or barley, you can eat rice because it does not contain gluten. So you have to avoid all sorts of gluten containing foods. Whipple disease, the specific treatment is ceftriaxone and then followed by trimethoprim sulfamethoxazole. Topical sprue, same treatment, trimethoprim sulfamethoxazole, doxycycline. Carcinoid syndrome. Carcinoid syndrome presents with intermittent diarrhea in association with flushing, wheezing, cardiac abnormalities of the right side of the heart. So it presents with intermittent diarrhea in association with flushing, wheezing, and cardiac abnormalities of the right side of the heart. The best initial diagnostic test is the urinary. This is important. 5-HIAA test. 5-HIAA test. Urinary 5-hydroxyindole acetic acid test. 5-hydroxyindole acetic acid test. Treatment is octreotide, a synthetic version of somatostatin, to control the diarrhea. So the carcinoid syndrome treatment is what? Octreotide, which is a synthetic somatostatin. The best initial diagnostic test is 5-hydroxyindole acetic acid test. Lactose intolerance. No weight loss is associated with lactose intolerance because lactose is only one of several sugars to absorb. Lactose intolerance does not alter the absorption of any other nutrients such as fat. So if a person is having the problem of lactose intolerance, she or he does not necessarily need to be having weight loss. So because it's just the intolerance to the lactose only, and lactose is only a single portion of several sugars out there. So it does not alter the absorption of any other nutrient such as fat. So there is no deficiency in calories. The problem is just with the lactose molecule. Vitamins are absorbed normally, fats are absorbed normally, other nutrients are absorbed normally. Stool osmolality is increased because of the lactose intolerance. The lactose is not absorbed, it increases the stool osmolality. Diagnosis is typically made by removing all milk containing products from the diet and waiting a single day for resolution of symptoms. So, this is how you diagnose it. It is diagnosed clinically. Typically made by removing all milk containing products and then waiting a single day for resolution of symptoms. Treatment is the avoidance of milk products except yogurt. Oral lactase replacement is also effective and available over the counter. So you can have lactase because if there is lactose intolerance, the patient does not have integral portion of the lactase. So then he or she is advised to take the oral lactase replacement. You can take oral lactase replacement. It is also effective and available over the counter, OTC. But the main treatment is to avoid the milk products except yogurt. Irritable bowel syndrome, IBS. Irritable bowel syndrome is a pain syndrome that can have diarrhea, constipation, or both. So it is either diarrhea dominant, constipation dominant, or mixed, both. IBS is not associated with weight loss, same as the lactose intolerance. Pain does not automatically mean malabsorption, but it is a pain syndrome. There is no specific diagnostic test for IBS. It is a diagnosis of exclusion in association with a complex of symptoms. So it is diagnosis of exclusion. The pain of IBS is relieved by a bowel movement. Less at night, it is less at night. Relieved by a change in bowel habit, such as diarrhea. IBS is not associated with blood or WBCs in the stool. Treatment is as follows. Fiber in the diet. Start fibrous food. Antispasmodic agents such as hyoscyamin, dicyclomine, peppermint oil, etc. So these are antispasmodic agents in order to get rid of the pain complaint. You can also give tricyclic antidepressants, for example, amitriptyline or SSRIs. Additional treatment for diarrhea dominant IBS, and then there is additional treatment for constipation predominant IBS. So fibrous diet and antispasmodic agents and TCAs you can give in both of them, but there are specific additional treatments for each one of them. Let's discuss that now. Rifaximin, non-absorbed antibiotic with modest effect in diarrhea predominant IBS. Elocitron is basically inhibitor of serotonin with modest effect in IBS. So, but it needs special permissions to use. Eloxodolin and then probiotics. So these are the options. Additional treatment for constipation predominant IBS, go for the fibers, polyethylene glycol. So polyethylene glycol PEG is also a non-absorbed bowel lubricant. lubiprostone, and linaclotide. So if PEG does not work, polyethylene glycol, you can go for lubiprostone, and you can also go for linaclotide. Inflammatory bowel disease. Inflammatory bowel disease is an idiopathic disorder that presents with diarrhea, blood in stool, weight loss, and fever. Both Crohn's disease and ulcerative colitis have extra-intestinal manifestation that can be identical in both diseases. These are arthralgias, uveitis, iritis, skin manifestation, sclerosing cholangitis. So, inflammatory bowel disease is an idiopathic disorder that presents with diarrhea, blood in the stool, weight loss, and fever. Diarrhea, blood in the stool, weight loss, and fever. Both Crohn's disease and ulcerative colitis have extra-intestinal manifestations that can be identical in both diseases. These are arthralgias, pain in joints, uveitis, iritis, involving the eyes, skin manifestation, that is erythema nodosum and pyoderma gangrenosum, sclerosing cholangitis, that is more frequent in ulcerative colitis. See, the erythema nodosum is actually an indicator of disease activity, while the pyoderma gangrenosum and primary sclerosing cholangitis do not change with the disease activity of IBD. It is important to remember that both forms of IBD can lead to colon cancer. The risk of colon cancer is related to the duration of the involvement of the colon. So, Crohn's disease that involves the colon has the same risk of colon cancer as UC, as the ulcerative colitis. Here is CD versus UC. So, Crohn's disease have skip lesions while ulcerative colitis does not have skip lesions. It is curable by surgery. The granulomas here are transmural, involving the entire bowel wall and all the layers of the bowel, while in ulcerative colitis it is entirely mucosal only. So in Crohn's disease, transmural; in ulcerative colitis, mucosal. Fistulas and abscesses are present in Crohn's disease. No fistulas, no abscesses in UC. Masses and obstruction are there in Crohn's disease. No obstruction in UC. Perianal disease is present. No perianal disease in UC. When should screening occur? This is the most important point. So after 8 to 10 years of colonic involvement, with colonoscopy every 1 to 2 years. So if colon is involved in these IBDs and 8 to 10 years pass, then you should do the screening with colonoscopy every 1 to 2 years. Diagnostic testing includes endoscopy, which is the most accurate test. When disease can be reached by a scope, then is the endoscopy the most accurate test and the better option for diagnostic testing. Radiologic testing, for example, barium study for CD or Crohn's disease, that is mainly in the small bowel to detect any lesions. So in those cases, when endoscopy cannot reach the disease point, we go for the radiologic testing, that is barium study. Serologic testing, when the diagnosis is still unclear. So all IBDs are associated with anemia as well. You know why? Because of the blood in the stool. Okay, so we've got two antibodies, that is ANCA and ASCA. Anti-neutrophil cytoplasmic antibody and anti-Saccharomyces cerevisiae antibody. So the ANCA test is positive in ulcerative colitis, while the ASCA test is positive in Crohn's disease. So anti-neutrophil cytoplasmic antibody test is positive for ulcerative colitis, and anti-Saccharomyces cerevisiae antibody is positive for Crohn's disease. Treatment is as follows: steroids for acute exacerbations, both UC and CD. 5-ASA derivatives such as mesalamine for chronic maintenance of remission. So we go for 5-ASA derivatives, mesalamine. For ulcerative colitis, Asacol, that is mesalamine, or Rovasa mesalamine if limited to the rectum. In Crohn's disease, Pentasa, that is mesalamine, or ciprofloxacin plus metronidazole for perianal Crohn's disease. Steroids, prednisone, budesonide, azathioprine, 6-mercaptopurine to wean patients off steroids. Similarly, calcium and vitamin D for all, anti-TNF agents for fistula, and severe disease unresponsive to other agents. If it is not effective, check drug level. If drug is adequate, check for antibodies to the TNF inhibitor. If antibodies are present, switch to another TNF inhibitor drug. Switch to another anti-TNF drug. If not, switch to another class of biological agent. So you have to modify the therapy accordingly. If there is no response, then surgery is done. Neither form of IBD is routinely treated with surgery. Surgery is done at the last resort, following the entire plan which I just discussed. UC can be cured, however, with colectomy. Ulcerative colitis can be cured with removal of the colon, the entire portion. In Crohn's disease, surgery is used exclusively for bowel obstruction. CD will tend to recur at the site of the surgery. If the disease is refractory to all other treatments, give vedolizumab, alpha integrin inhibitor. IBD treatments, anti-TNF, we have got adalimumab, infliximab, certolizumab, golimumab, and etanercept. Anti-interleukin 12 and 23, ustekinumab. Similarly, budesonide is a steroid specific to IBD. Budesonide is a steroid specific to IBD. First pass effect is good for IBD treatment. Short bowel syndrome. It is seen in patients who have had at least half of the small bowel removed. So most often as a result of multiple surgeries to relieve obstruction in Crohn's disease. Because we studied that obstructions are there in Crohn's disease and it usually involves the small intestine, and we go for surgeries for that. Symptoms include diarrhea, symptoms of a short bowel syndrome, dehydration and malnutrition, and weight loss from steatorrhea. Steatorrhea is basically the foamy, fatty, and floating and foul smelling stool, which is caused due to the malabsorption problem. So the key finding is deficiency is vitamin A, D, E, K, that is the fat soluble vitamins, B12, calcium, magnesium, iron, and zinc, making it look like celiac disease. So all of these nutrients and minerals are deficient in such patients. And the symptoms include what? Diarrhea, dehydration, malnutrition, weight loss. Treatment starts with a diet that avoids high fat foods. So IV hyperalimentation may be needed long term. Loperamide to slow the bowel, and teduglutide is a GLP agonist that slows the bowel and increases the surface area. Vitamin supplementation. This is the treatment. Now, small intestine bacterial overgrowth. Small intestine bacterial overgrowth, that is SIBO, results from progressive dilation of the small bowel as the body's adaptation to resection. Normally, the small bowel is sterile, but in SIBO, the loss of the ileocecal valve lets bacteria in. So once you resect the portion of bowel, the small bowel tries to dilate progressively as the body's adaptation to resection. So usually the small bowel is sterile, it does not contain the bacteria, but in patients of small intestine bacterial overgrowth, the loss of the ileocecal valve lets bacteria in. So then the patients present with flatulence, bloating, diarrhea, steatorrhea. Diagnosed with small bowel aspirate with quantitative cultures. Treat with antibiotics. Rifaximin is first of them. Microscopic colitis. Microscopic colitis is caused by chronic, non-bloody, watery diarrhea. Tissue appears normal at the time of colonoscopy, but pathology of a biopsy reveals inflammation. So colonoscopy is normal, but biopsy reveals inflammation. It is caused by chronic non-bloody watery diarrhea. In other words, there is colitis, but you can only see the cause under a microscope. A clue to diagnosis is autoimmune disease in the patient history. Varieties of microscopic colitis include lymphocytic, collagenous, mastocytic. All may respond to steroids. Diverticular disorders. Diverticulosis. Diverticulosis is basically outpocketings of the colon. Is so common on a standard meat-filled diet as to be routinely expected in those aged more than 65. It is rarely seen in vegetarians. So meat-filled diets, diverticulosis. Most patients are asymptomatic, but they may present with left lower quadrant abdominal pain, constipation, bleeding, and possible infection, diverticulitis. Diverticulosis can occur anywhere in the colon, but in elderly patients, the sigmoid region is most involved, making it the most likely location for inflammation, the sigmoid region. The most accurate test is colonoscopy. Barium studies are acceptable but less accurate. Bran, psyllium, methylcellulose, and increased dietary fiber are used to decrease the rate of progression and complication. So, bran, psyllium, and methylcellulose and other increased dietary fibers are used. And what's the most accurate test? It's colonoscopy. Diverticulitis. So, when the question asks you about an older patient, about the most likely diagnosis, look for the left lower quadrant pain and tenderness. See, there is pain and tenderness along with it, and it's in the left lower quadrant. Fever, leukocytosis, possible palpable mass. Then it indicates the problem of diverticulitis. Nausea, constipation, and bleeding may also be present, but they are too non-specific for diagnosis. These are the specific things. Colonoscopy and barium enema are dangerous in acute diverticulitis. Colonoscopy and barium enema are dangerous in acute diverticulitis. Because of increased risk of perforation, infection weakens the colonic wall. So it's not like the diverticulosis where we go for colonoscopy as the most accurate test, and barium studies are also acceptable. But when it turns into an infection, and in cases of diverticulitis, we don't go for colonoscopy and barium enema. Once there is fever, leukocytosis, possible palpable mass, left lower quadrant pain and tenderness, because infection weakens the colonic wall and it can increase the risk of perforation. So what should we do then now? Then the CT scan is the best initial test in such cases. Treatment for the first bout of diverticulitis is medical if there are no complications warranting surgery. Treatment is antibiotics that cover the E. coli and anaerobes present in the bowel. Possible combinations include ciprofloxacin plus metronidazole or ceftriaxone plus metronidazole. So we do what? Ciprofloxacin plus metronidazole or ceftriaxone plus metronidazole for diverticulitis, and beta-lactam with beta-lactamase combinations. For example, amoxicillin and clavulanic acid, tecarcillin clavulanic acid, or piperacillin tazobactam, or etapenem that are carbapenems. Patients with acute diverticulitis should not be fed. Diverticulitis that is recurrent or not responsive to medical treatment will require resection of the affected loop of bowel. Surgery is also the answer for cases that involve perforation, fistula formation, abscess, stricture, or obstruction. So all of these things are the indication for surgery, or if it is recurrent and is not responsive to medical treatment. So we go for the surgical resection. Younger patients should have the colon resected more often than older patients because of the greater total number of recurrent episodes that will occur. That's why we resect it right away. Diverticular disease does not disappear despite treating episodes of diverticulitis or the use of fiber in the diet. So it's not that easy to go away. The most common complication after diverticulitis is abscess formation. So most common complication after diverticulitis is what? Is abscess formation. Colon cancer screening. The far majority of colon cancer deaths are preventable with screening. Which of the following is the most effective method of screening for colon cancer? The answer is colonoscopy. Since 40% of colon cancer occurs proximal to the rectum and sigmoid colon, colonoscopy is far more sensitive than sigmoidoscopy in detecting lesions. and FOBT, that is fecal occult blood testing, has more false positives and false negatives than colonoscopy. In addition, a positive FOBT must be followed up with colonoscopy. So you can't just decide just on the basis of the FOBT, positive FOBT, that there is cancer. You still have to follow it up with colonoscopy. Barium study, virtual colonoscopy with CT and capsule endoscopy do not allow for biopsy. So without biopsy you cannot decide whether there is cancer or not. So colonoscopy is the best option and the most effective method for screening for colon cancer. Capsule endoscopy is used to detect sources of bleeding in the small bowel not reachable by endoscopy. We have already studied this point. Virtual colonoscopy is never the correct answer for anything. The recommended frequency of screening is as follows. These are the important points from MCQ's point of view and Viva point of view. So the recommended frequency of screening is as follows. Routine testing, beginning at age 50, do a colonoscopy every 10 years. If previous adenomatous polyp, screen with colonoscopy every 3 to 5 years. If previous history of colon cancer, screen with colonoscopy at 1 year after resection, then at 3 years, then every 5 years. If family history of colon cancer, single family member, start screening 10 years earlier than the age at which the family member developed cancer or age 40, whichever is younger. Start it at the younger age between the two. Repeat the scope every 5 years if the family member was aged less than 60. 3 family members, 2 generations, 1 premature, age is less than 50. That is hereditary non-polyposis colon cancer syndrome HNPCC. Start screening at age 25 with colonoscopy every 1 to 2 years. Familial adenomatous polyposis. Beginning at age 12, do a sigmoidoscopy every year. Familial adenomatous polyposis, the presence of thousands of polyps, is identified with an abnormal genetic test known as APC test, adenomatous polyposis coli test. Anticoagulation in colonoscopy. So stop NOx 1 day before colonoscopy. Restart them the day after colonoscopy. If colonoscopy is on Tuesday, skip Monday's dose and restart on Wednesday. This is important. So when you are about to do colonoscopy, stop the NOx anticoagulants that you are taking 1 day before colonoscopy. Restart them the day after colonoscopy. So if colonoscopy is on Tuesday, skip Monday's dose and restart on Wednesday. Stop warfarin 3 to 5 days before colonoscopy. 3 to 5 days before. Use the shortest period of time of warfarin in patients with metal heart valves, because you need warfarin there. So try to keep the time of warfarin the shortest as possible, as short as possible. Other polyposis syndromes: Peutz-Jeghers syndrome, Gardner syndrome, Turcot syndrome, juvenile polyposis. Now let's see. Peutz-Jeghers syndrome is characterized by multiple hematomatous polyps in association with melanotic spots on the lips and skin. These are the extraintestinal manifestation. Increased frequency of breast cancer, increased gonadal and pancreatic cancer. The frequency of colonoscopy screening is increased to every 3 years starting at age 8. Screen age 8 Pets screen age 12 familial adenomatous polyposis and juvenile polyposis. So in Pets syndrome there are multiple hematomatous polyps, melanotic spots on the lips and skin is an association. Increased frequency of breast cancer, increased gonadal and pancreatic cancer. So you have to start screening right at the age 8. And the frequency of colonoscopy screening is increased to every 3 years starting at age 10, at age 8. Gardner syndrome. So Gardner syndrome is colon cancer in association with osteomas, desmoid tumors, other soft tissue tumors. So it is associated with osteomas, desmoid tumors, other soft tissue tumors. Put Gardner syndrome in the same place in your brain as FAP regarding cancers outside the colon. It is similar to FAP in its long-term risk of colon cancer and has greater incidence of cancer of the thyroid, pancreas, and small bowel than FAP. Screen Gardner syndrome from the same starting age of 12 with sigmoidoscopy. So Gardner syndrome, like, put it in the same place in your brain as FAP regarding the cancers outside the colon. Greater incidence of cancer of thyroid, pancreas, and small bowel. And screen Gardner same starting age of 12 with sigmoidoscopy. Turkel syndrome is colon cancer in association with CNS malignancy. This is the distinguishing point. Try to understand it by comparing the Turcotte code with turban. So CNS. Turban is near the CNS. Juvenile polyposis. Juvenile polyposis is colon cancer in association with multiple hematomatous polyps. Screen both and lower GI tracts at same intervals as FAP. For today and for this lecture, I think this is enough, and I'll try to cover the remaining part of the gastroenterology in the next lecture. I would start from the pancreatic disorders up until the last topic, inshallah. Peace be unto you all. Goodbye.